Hi, thank you for joining us today for a very important and informative webinar, Understanding Behavioral Challenges in Lewy Body Dementia. I'm Teresa Johnson with the National Adult Day Services Association. I am physically located in North Carolina today, where it is warm and sunny. And we will be joined by two other folks. One is Angela Taylor, who is with the Lewy Body Dementia Association. She is located physically today in Pennsylvania. Gotta love technology when it works. And Dr. Glenn Smith is also joining us, and he is in Minnesota with the Mayo Clinic. And so just wanted to get some housekeeping items covered, and then we will transition over to the other presenters. I do want to draw attention to the chat feature on the right panel. If you have any questions or comments or any kind of issues related to technology, if the sound is not working or if you can't see the screen or something, please do enter that information, and we'll be monitoring that throughout the presentation today. We would ask that you enter any kind of questions that you have throughout the presentation, and then after everyone has finished presenting, we will be recognizing those questions and directing them to the appropriate presenter, and look forward to your participation. We have many people from all across the country. Some people are direct care workers, some nurses, and then others who are administrators in adult day programs. And so we are just delighted to have our presenters and talk on such a very important topic. In general, adult day programs have a large percentage of people, especially if they're a center that's serving older people, a large percentage that have dementia. Sometimes there may be specific centers serving people with dementia, but the ones we're going to talk about today is specifically the Lewy Body Dementia. And so we really appreciate your time, and wanted to let you know that we will be sending an evaluation email tomorrow, and so you can anticipate that coming over as well. The National Adult Day Services Association is a member organization, and we serve people in the over 5,000 adult day centers across the country, and we have some members in Mexico, Canada, and a couple of other countries. So we really appreciate your participation and look forward to the information that is going to be shared in the presentation today. The first person I want to recognize is Angela. She will be talking to us a little bit about the Lewy Body Dementia Association, and then she will be transitioning us to our key presenter today, Dr. Smith. So Angela, are you ready for me to change the slides over to you?
Yes, I am. Thank you. Okay, hopefully you'll be able to see my screen without any problems. I'd like to thank Teresa for working with LBDA on this important webinar. As she said, this is a topic of, as you can imagine, great importance to us. We're happy to have Dr. Smith here with us to help inform you about the important challenges that you might navigate with LBD and the patients that you serve. I'll tell you a little bit about our organization. LBDA is a 501c3 national nonprofit health organization, and we dedicate ourselves to raising awareness of Lewy body dementia, supporting people with their LBD, their families and their caregivers, and promoting scientific advances and the early diagnosis of LBD. Through outreach, education, and research, we support all of those affected by LBD. Some of our programs and services that are most helpful to families include our caregiver link, which allows individuals to speak one-on-one with an experienced LBD caregiver who volunteers with our organization. And that really helps them feel that they're not alone, and they can get some, practical everyday advice about what it's like to live with the disease. And that those calls are completely confidential. It's important to note that this is not a hotline, that this is a helpline, so calls are not answered immediately, but it's a wonderful resource to families. Additionally, we have a national network of support groups across the country. These groups provide those affected with LBD and their care partners an opportunity to connect with others as they deal with the challenges on a day-to-day basis with the disease. And you can find a list of those support groups on our website at lbda.org. Our discussion forums is a 24/7 resource. We know it can be difficult for caregivers to attend support groups in person, and so we created our forums where they can meet and share their experiences and their insights with other people. And to join it, all they have to do is send an email to forum@lbda.org. We have over 3,000 members on the forum, so it's a very active place. In addition, in October of every year, we organize volunteers to help us raise awareness. This is a grassroots effort to increase awareness to the general public, to the media, and medical communities. And we like to collaborate with local organizations. So, we invite you to reach out to us if raising awareness is something that you'd be interested in doing as well. Like this webinar, we offer live educational webinars on a variety of topics every year. Our target audiences are generally the family care provider as well as allied health care providers. And we also have a wide array of educational materials that are available both in print and electronic form. So those might be something that you might want to have on hand at your facility in case there's families who are looking for more information. And if you're not familiar with our website, it is the one source for really credible information on LBD. We have hundreds of thousands of visitors a month. So you can go there and sign up for our free e-newsletter to stay up to date on information about the disease and new resources that we have. You can follow us on Facebook, and you can also follow us on Twitter. Our webinars are archived on YouTube, and we also have public service announcements that you can help raise awareness about LBD with those. So here's our contact information. We welcome you to visit our website or to reach out to us at lbda@lbda.org. And at this stage, what I'd like to do is introduce our speaker. Dr. Glenn Smith is a board-certified clinical neuropsychologist who specializes in neurocognitive disorders. He's a professor of psychology at the Mayo Clinic College of Medicine and a member of the Division of the Neurocognitive Disorders at Mayo Clinic's Department of Psychiatry and Psychology. He's a past principal investigator of the Mayo Alzheimer's Disease Research Center Educational Corps, and he's the clinical director of the Alzheimer's Disease Resource on mayoclinic.org. He's the associate director of the research education programs within Mayo's clinical and translation sciences activities. Dr. Smith is the founder and director of a program called HABIT, Healthy Action to Benefit Independence and Thinking for people with mild cognitive impairment. Dr. Smith, if you're ready, I'd like to turn the control over to you.
Great, thank you. While she's handing off, let me thank Teresa and Angela for this great opportunity to talk to you all. And thank you all for being present, and especially thank you for the very important work that you do in serving populations with dementia or dementing illnesses. See if I can handle the technology challenges myself here. So I'll ask Angela and Teresa if my screen's showing okay and my volume's okay.
Yes, looks great to me.
Great, good. Well, first a few disclosures. Just want folks to know it's kind of standard in our field these days to let people know what might motivate you. So I've had funding from both the National Institute of Health and from something called the Patient-Centered Outcomes Research Institute, and benefactor funding from the Ralph C. Wilson Foundation. I'm the author of a book with my friend and colleague Mark Bondi on mild cognitive impairment and dementia, and I'm in a chief editor of a book that will be coming out next year, The Handbook of Dementia by the American Psychological Association. And I want to talk today about behavioral challenges that we encounter in dementia a little bit broadly, but with special attention and focus to those things we see in Lewy body disease. Have you all think with me about some of the mediators of challenging behaviors in Lewy body disease and other dementias, and try and encourage at least 3 person-centered strategies for reducing challenging behavior as care providers encounter it in a variety of settings. So let me just start by asking you to imagine that you're providing care for an 83-year-old woman, that she seems to be seeing things that aren't there, and that generally she's somewhat agitated when this happens. So in order to try and help this person, what else would you want to know to try and best meet her needs? So that's a little thought experiment for you to keep in mind. You know, typically a health provider, someone like me, would want to know about her history. So it'd be important to understand that she's having some vision problems due to macular degeneration. We'd want to know what medications she's on, and would note with interest that she's on a Parkinson's disease medication that's associated with hallucinations sometimes. We'd want to know how severe is her cognitive impairment, and we'd want to know exactly what is the nature of the hallucinations she's having, and are there any other associated challenges. So this is some of the things we might find out as we poked and prodded about this particular patient. And so what would we recommend? What would we recommend here to try and address this problem? Well, I would contend that often this is where we jump in, and we jump in a little bit too soon sometimes without perhaps understanding and considering who the whole person is. So it might also be important for us to understand, in a person-centered sort of approach to behavior challenges, that this person is widowed. She has a sister who's very devoted to her. She spent her life as a librarian. She has 2 children who are not nearby but very important to her, and that she loved to read and loved to go to the opera. I'll come back to why those bits of knowledge about her might be important a little bit later. Well, maybe I'll do it right now. Now I see I've got my recommendation slides here. One of the things that would be important in her case is to understand, in people who have to take medications to control Parkinsonism, that there's always a trade-off between how aggressively we can control the Parkinson's disease and how much risk there is for hallucinations. This is a very important topic in Lewy body disease, and I'll come back around to why that is later. But in this case, we recommended that we could talk directly to her about these hallucinations, and that she would probably be able to understand and remember this explanation. And in a little bit, I'm going to talk about how Lewy body disease, in some cases, but not all cases, is different from Alzheimer's disease, and specifically this context of the ability to remember things. But our very first recommendation here had to do with a philosophy that we have used in a consulting service called DeBART that I'll talk about in a minute. So I just wanted to give us a context, a case-based context, to talk about managing challenging behaviors in Lewy body dementia. And here's some of the things I'm going to try and cover in the next half hour to 40 minutes specific to that. A little bit about our DeBART team, a little bit about Lewy body dementia, and then some of the approaches, the role of medications, maybe briefly give you some sense of the empirical basis for these kinds of approaches and close with discussing proactive interventions. And one of the real challenges in all of dementia care, and particularly in Lewy body disease, is our nomenclature, how we describe symptoms. Because we know that dementing illnesses have not only changes in cognition or people's thinking, but also they produce the functional impairments that necessitate people's needs for things like adult day services. That some people can have psychiatric symptoms, but by that I mean symptoms of mood disturbance, for example, and that people will also have behavioral disturbance symptoms. And the last two often get conflated. They get confused with each other, and we don't do an adequate job often as mental health service providers of making distinctions between behavioral disturbance symptoms and psychiatric symptoms. Now, just to make the point about dementia and the behavioral symptoms, the original case described by Dr. Alzheimer's that led to the notion of Alzheimer's disease didn't present as a person complaining her memory was bad, but presented as a person who had this firm, fixed belief that her husband was being unfaithful to her. And it was in the process of providing psychiatric care for her that Dr. Alzheimer's later discovered that she was showing a deterioration in her thinking and cognitive functions. But behavioral disturbance or behavioral change is part and parcel of dementia, right along with the cognitive changes. So one of our challenges historically has been that as we see those behavioral disturbances, we're eager to apply psychiatric terms like paranoia, psychosis, and delusions to those terms, and then to treat those psychiatric syndromes with our traditional psychiatric medications, and in many cases, in my humble opinion, will sometimes jump the gun of true understanding of the behavioral challenge and what to be done about it. And I'll say this now and probably return to it. One of the dangers in Lewy body disease with engaging in this approach is that people with Lewy body disease and dementia due to Lewy body disease can have a hypersensitivity to particularly the antipsychotic medications. So we can actually make things worse in some cases by treating too soon and too aggressively. So let's talk about some of these terms, like in all dementias, but in Lewy body disease in particular, it's important to distinguish a hallucination, which is a false perception that occurs without any stimulus in the environment leading to that false perception. So our case was seeing small children around the environment, and there wasn't necessarily a chair or a bed or a pile of clothing or anything that would lead to that false perception. That's in distinction to a case I worked with at one time where late at night in her bedroom, this woman would perceive someone to be present in her closet, but only in her closet, and if the family closed the closet door, she wouldn't have that misperception. That woman was seeing the outline of clothing in her closet and misunderstanding that as a person. So in that case, she was showing what we would describe as a visual perceptual deficit, which can be common in Lewy body disease and isn't the same thing as a hallucination. So other kinds of terms we use, we'll talk about delusions. And Auguste D. had a delusion, a false fixed belief without an incorrect or without a perceptual basis. That's different from an illusion or a belief that's based on an erroneous interpretation of stimuli. The classic example of that in dementia is the person who hides their belongings because they think someone's stealing from them, can't remember where they hid their belongings, and that provides sort of de facto evidence to them that their things are being stolen from them. But that's based on the fact that they can't find their possessions, which is an illusion or a misinterpretation of real-world data as opposed to a delusion. In Lewy body disease, and I'll come back to this perhaps again later too, one of the common challenges we encounter, especially in early morning behavior, is that patients with Lewy body disease will often have strong dream content and will begin to be challenged sometimes about, did that really happen or was I just dreaming that? So it's not that an event didn't occur in their mental world, because it did. It's just they're losing their ability to distinguish what was dream content from what was real content. Calling that a delusion might be inappropriate in some cases. So the other common term we'll hear about, and that was used with this particular case, for example, is the term agitation. Agitation describes so many different behaviors that in some ways it becomes a non-descriptive term. Yelling out can be described as agitation. Refusing cares can be described as agitation. And those things are a long way away from the quote, agitated patient who actually is striking other patients or violating other patients' personal space. So this is why we believe it's really important not to merely apply labels to these behavioral challenges that are broad, but to be very descriptive about what you're actually encountering. And our experience in this regard comes from about 20 years of working myself and a psychiatry colleague with a program that we labeled the DeBART team, Dementia Behavioral Assessment and Response Team. Over the years, we developed the philosophy that there are going to be behavior problems in dementia. Thinking there won't be behavior problems is like thinking there won't be thinking problems, that it's part and parcel of the disorder. And so pursuing the cure for behavioral problems in Lewy body dementia and other dementias can be elusive. And we have to recognize oftentimes that treatment success is merely reducing the frequency or intensity of challenging behaviors. The other thing we learned quickly, hopefully you'll appreciate, is that dementia, the progression of a dementia, results in a person who's less and less able to adapt to a given environment. And in many, many cases, it's easier to fix the environment than it is to force the patient to adapt to it. And finally, it's important to always recognize that behavior, for all of us, behavior is a form of communication, and that in people with progressive cognitive decline, behavior becomes an increasingly useful form of communication because verbal skills can deteriorate as dementia progresses. So as we've tried to manage disruptive behaviors in patients with Lewy body and elsewhere, we've had to recognize that behaviors compete in real time. I'm here talking to you now. That means I can't be out playing tennis, for example. But when we try and use one behavior to substitute for another behavior, we have to be mindful that behaviors have to be appropriate to the level of impairment in the person. We've been called out as a DeBART team often to try and help fix behaviors once they've occurred. That's not a very successful strategy. It's always been more helpful if we could think of ways to keep the behaviors from occurring in the first place, to be proactive, not reactive. And finally, you have to use what the dementia provides to you. and you have to be aware of what it doesn't. And Lewy body dementia due to Lewy body disease is especially challenging when we keep this in play, this notion in place. I'll talk about that a little bit more, I think, in a minute. But using this kind of philosophy, we found that we can have frequent success in managing problem behaviors. So this is just some data from 50 consecutive dementia patients we worked with in a whole variety of different settings, from their own home to a skilled nursing, occasionally to day programming. You can see where the bars go up, those were people we made worse, quote unquote. Where the bars go down, those are reductions in frequency of disruptive behaviors, and where there's no bar, that means we had no change. So I put that out there humbly to recognize that these strategies don't work every time, but they work a lot of the time, and especially in the modern era as regulators, including Medicare, are pressing care providers to reduce their utilization of psychiatric, psychotropic, and especially antipsychotic medications. The kinds of strategies I'm sharing with you today hopefully fill a void and have some utility. If you average all those data points I just showed you, this is meant to show that this type of strategy can have a statistically significant effect in terms of improving people's behavior. So after a lot of years of doing this, this is the strategy that we encourage folks to try and operationalize in the care settings that they're providing care to patients with dementia. I talked about the nomenclature issues. I'm going to talk next about understanding the dementia etiology, and this is where we really get into the specifics of what Lewy body is and what it does. In the case of case 1, we noted a severity. She scored 22 out of 27 on a modified mental status exam, which would be a mild level, very mild level of dementia. That was an important part of how we thought about her. I talked about the importance of behavioral communication. That first line is understanding all about the patient. The second line is figuring out what to do with that patient once we understand more about her. And this would be a management approach we encourage folks to go step by step through. So let's go back to case 1. Her etiology was dementia due to Lewy body disease. I'll talk about the features that proved that in just a minute. Her behavior were real hallucinations. The mediators of that behavior were her medications, along with the Lewy body dementia. But her history gave us some targets to try and address, because as I'll get to later, we firmly believe that you can't create a behavioral vacuum. That is, you can't just focus in dementia behavior management only on reducing behaviors, because you're trying to create then an absence of behavior, and that's just impossible. Humans behave. So we have to always be mindful of what we're trying to increase as well as what we're trying to decrease. So Lewy body dementia exists in this whole cascade of possible cognitive impairments that you all probably encounter as providers out there. Not all cognitive impairments you encounter are dementia. Some of them are transient. Some of your patients will have a delirium, which is an acute decline in cognitive function that will resolve with appropriate treatment. Some of your clients may not yet have dementia, even though they're having some cognitive change. And even if they do have dementia, not all dementias are non-reversible, and not all non-reversible dementias are degenerative. But Lewy body disease, dementia due to Lewy body disease, falls in that category of a degenerative dementia syndrome, along with Alzheimer's, most vascular disease-based dementias, and frontotemporal dementia. These different causes of dementia have a different behavioral profile. So Alzheimer's disease is first and foremost a memory-based syndrome, and a lot of the behavioral disturbances that ensue reflect people who are forgetting and progressively living their lives more remotely in their remote history. So perhaps you've encountered the dementia patient who believes that their kids are still living at home and that they have to get out of your setting, your program, to get home and take care of the kids because they're going to be home from school. That reflects a deterioration of recent memory and a retrogression into very remote memory that's characteristic of Alzheimer's disease. Lewy body dementia tends to have a big component of this problem of hallucinations and disruption of sleep-wake syndromes. So Lewy body patients can be very hypersomnolent. They can have these false beliefs that ensue from the disruption of their sleep-wake kinds of control. And they also have very prominent problems with attention and visual spatial reasoning in distinction to Alzheimer's disease. Now I want to stop and give you a cautionary bit of neuropathology to help you understand. I'm going to show you a slide in a minute about what is a Lewy body disease. But we talk in Lewy body dementia often about common versus pure. That's kind of an old nomenclature, but it helps me to think about this disorder. Pure Lewy body disease, those patients have only Lewy bodies in their brain, and they account for a minority of the number of Lewy body dementia cases we see. In common Lewy body dementia, you see not only Lewy bodies in the brain, but also amyloid plaques and neurofibrillary tangles. Those two pathologies are the pathologies of Alzheimer's disease. So in many, many cases, there's a big overlap between the changes of the brain of Lewy body disease or Parkinson's kinds of changes and those of Alzheimer's disease. So it can look kind of like a blending. So in autopsy samples, Lewy body dementia tends to be the second most common form of degenerative dementia. Probably in epidemiologic samples, vascular dementia and Lewy body dementia are roughly equal as the second and third most common forms of degenerative dementia after Alzheimer's disease. And the more we learn, the more we realize that these pathologies are highly overlapping, and it's more common to have a mixed neuropathology than it is to have a pure neuropathology. So what is a Lewy body? Well, we've known about Lewy bodies for a long time, almost as long as or longer than we've known about Alzheimer's, because Lewy bodies often appear in a part of the brain called the substantia nigra that's important for controlling movement. And way back when, even in the days of Alzheimer's, we could stain for those Lewy bodies and see them in that region of the brain called the substantia nigra. And we came to understand that this was probably what was causing the symptoms of Parkinson's disease: rigidity, tremor, shuffling gait, stooped gait and posture, masked or flat faces. Those are the features of Parkinson's disease, and they probably emanate from, see if this works, this protein that was developing in the brain cells in the substantia nigra. And here you see it stained differently. That's what a Lewy body disease, Lewy body is. As we developed more modern and more sophisticated ways to stain brain tissue, and what you're seeing here are thin slices of brain tissue that have been stained, we began to realize that in some patients, Lewy bodies and related pathologies existed not just in the substantia nigra or the movement parts of the brain, but in other regions that were important for thinking and for processing information. And that's when we began to be aware that you could have not only subcortical Lewy bodies, but cortical Lewy bodies. And when the cortex gets involved in a neuropathology, you're going to get not just movement changes, but thinking changes and behavioral changes as well. So Lewy body dementia is clinically diagnosed as a person who shows at least 2 of 3 key clinical features, and work that we've done here at Mayo Clinic has strongly suggested a 4th key clinical feature can help us diagnose Lewy body disease. For Lewy body disease to be called Lewy body dementia or dementia due to Lewy bodies, you have to first start with a person who has dementia. And let me just be clear and specific about that. A dementia is diagnosed when a person has impairment in at least 2 areas of their thinking, like memory and reasoning, or attentional processing and visual spatial processing, or so on and so forth, and that impairment in those 2 areas of cognition is sufficient to interfere with their daily function. So people are starting to have trouble carrying out normal routine daily function due to those thinking skills. And that has to represent a decline from a previously higher level of functioning and not be due to delirium. So if you have dementia, then clinicians will look for 2 of these 4 following things: Parkinson's symptoms, which I mentioned previously, the shuffling gait, the rigidity, the tremor, the masked faces, the stooped posture, etc. Then fully formed hallucinations. What that means is that people aren't just seeing flashes of light or colors or a sense of movement, but they're actually seeing things. The case 1 saw small children that weren't there. Then there's the 3rd criterion of fluctuating cognition. And as we've studied this at Mayo Clinic, we tend to think of this as representing this issue of poor sleep-wake separation, because what fluctuating cognition looks like is someone who was awake and alert and processing information fairly well will sort of have this kind of cloud or veil drop down, and suddenly you're interacting with someone who's not really able to process information well. And it's almost like a mini delirium in some cases. I was talking to a man in his hospital room one time, and we were having a very normal conversation, and then his eyes kind of became glassy, and he started trying to climb up the cabinetry in his room. He was clearly now in a different state of consciousness, and after a while that subsided, and he was back to being alert and able to interact with me. So that's one example of what we mean by fluctuating cognition. And in that regard, as we've studied people with Lewy body disease, we find that they have problems with maintaining wakefulness during the course of the day. So they'll tend to sort of doze easily and quickly, and that may be a component of the same thing. Then on the other side, there's what we call REM sleep behavior disorder, rapid eye movement sleep behavior disorder. REM sleep is that phase of sleep where you're dreaming. It's the deepest stage of sleep. During that stage of sleep, there's actually kind of a switch in our brainstem that turns off our muscle tone. If that switch didn't work, we would all act out our dreams at night. We would all move during dreaming, because in the higher regions of the brain, the nerves are firing, and those dream experiences we're having are because our brain cells are firing. And with our brain cells firing, it sends signals down through our brainstem to our spinal column telling us to act and move, except that there's this part of the brainstem that seems to shut that off. And we can actually measure during dream sleep that you have no tone in your peripheral muscles. But for some reason, in some proportion of Lewy body patients, that switch goes awry, and they will have muscle tone during dreaming. And as a consequence, it's fairly common to hear stories, especially from bed partners, because the person themselves is in such deep sleep they may not recognize that they're moving unless and until they throw themselves out of bed or kick off the covers. But bed partners will often tell us about having been elbowed or kicked or struck as that person is engaging in REM sleep behavior. And so this is a very important component of Lewy body disease. Now, we've studied over time how these different components of Lewy body disease emerge as people develop Lewy body dementia. And oftentimes that's in those people, which is about 2/3 to 3/4 of the people who develop Lewy body dementia, that strange sleep disorder will appear sometimes 5, sometimes 10 years before any other symptoms. And then the next thing to see in green here is the cognitive, the next thing we can see is the Parkinson's disease. And then the next thing we will see are some of the cognitive changes. And then finally the hallucinations. And last but not, I'm sorry, not finally, but next the hallucinations. And then last but not least, the fluctuations. But you'll note that if the age of onset is late, not young, this can flip around so that we'll see Parkinsonism first and cognitive changes early, and the sleep problem, if it occurs, will tend to develop later than that. So there does seem to be a bit of a feel of young onset versus late onset differences. Now, I want to really emphasize at this point that when we talk about dementia, whatever kind, we say if you've met one person with dementia, you've met them, well, no, you've met one person with dementia. And that's especially true in Lewy body disease. Some people present first with cognitive changes, some first with Parkinson's disease, some first with REM sleep behavior disorder, and some first with fluctuations. So what you're seeing here is an average, but it's not descriptive of any given person necessarily. I'm just going to skip over that. Probably skip over this too. This is just our understanding of why the things typically change that way, that there's this long period in all dementias, but certainly in Lewy body dementia, where the Lewy body protein, those Lewy bodies are made up of a protein called alpha-synuclein, and that's beginning to deposit in the brain well before you see any changes in behavior or function. And it's a decades-long process probably before you start to see the emergence of sleep changes, of cognition changes, of Parkinsonism, and fluctuations, for example. So I want to share with you an important additional philosophy. Having explained why it's really important to understand what's causing the dementia that you see in patients or clients you work with, it's also important to recognize that as things progress, these distinctions are probably less important, and what's common across the dementias begins to take over. So that's part of why it's important to assess how severe a person is. Let me now shift and start to talk about, so what do you do? When you have a person with dementia, due to Lewy bodies that you're encountering in your setting, and how do you help to serve them? The first thing is to remember behavior is communication. So it's not random. It's probably adaptive for that person, and it's often goal-directed. The challenge is that the person can't always tell you what the goal is, what they're trying to adapt to, so it can feel random to you. And I will acknowledge in some cases it's nearly impossible to figure out what it's communicating. But it's important to start with the presumption that we have to ask what's the behavior communicating. And why one of our favorite cartoons is the one where Marvin says, why do you throw loud, or Marvin's mom asks, why do you throw loud tantrums? And he says, because I lack the verbalization skills to express what's really hacking me off. Now, early in the course of Lewy body, attention problems, visual spatial problems will predominate, but language will be much more intact than it might be in an Alzheimer's disease patient of a comparable disease severity. So I would say that even as it's important to consider language decline because all dementias converge, it's also important to recognize Lewy body patients, when they're not having these fluctuation episodes that reduce their overall ability to interact with their environment, can have pretty good verbalization skills. But if you're asking the question anyway, what is the behavior communicating? These are some of the things that you will undoubtedly, if you've been at this a while, recognize as some of the things that this challenging or disruptive behavior communicates. Pain, boredom, a setting that's either too busy or not busy enough for that particular person. Many times it's depression or anxiety. And what are some communicated? Well, pain is just one example of physical and health factors. In many, many settings, we're very attuned to both pain, to urinary tract infections, to constipation, but there can be other physical health factors as well. We worked with a setting once where the person was continuing to go for dialysis because they had chronic kidney failure long after they were able to communicate their wishes about dialysis. And the agitation probably just reflected that the patient didn't want to continue to have that disruptive experience in his life. Psychological health factors are depression and anxiety. The environment being too busy or not busy enough, I've already talked about. Sometimes disruptive behaviors just reflect social history. We cared for a patient once who was constantly trying to leave the care setting they were in, but only between 3 and 4 o'clock in the afternoon. The staff said, well, see, look at this person's engaging in sundowning. And we said, well, really what's happening here is that the person used to go home from their job at the post office every day at 4 o'clock. And now you all are putting on your coats every day at 3:30. Coats, this is Minnesota, we wear coats year-round. Every day at 3:30, and that's cueing this person that it's time to go home. So we fix that behavior problem simply by having those people put on their coats out of sight of the patient and go out the back door instead of the front door and not trigger their social history. You have these slides, I hope. I think Teresa sent them around to you, so I won't belabor these specific examples because I've just mentioned them. But these are things to consider as you're trying to manage folks with challenging behaviors. This is just kind of a rough schematic for how we think about level of cognitive impairment and risk for over or under stimulation. So this is a score reflected on something called the mini mental state exam. Some of you will be familiar with it, but not all of you. It's a 30-point scale where you ask people things like what day is it, what year is it, where are we? You ask them to remember some words and do some calculations. Pretty commonly used, and what we find is that in many care settings, people who are still above the 20s that might be using those care settings tend to be bored. The settings typically don't offer them a rich enough environment. But when you get down into the single digits, then congregate care, where you have large groups of people together, can be very challenging and overstimulating. And so it's important to align the care setting with the ability of the person to engage in it in terms of their information processing systems. I want to talk for just a minute, importantly, about redirection, because at least in skilled nursing settings and probably in day programming as well, this is the most commonly used approach to dementia behavior management. The care plan often calls for redirection. And in many, many situations we've encountered the challenge with redirection is it's basically code for telling the person no or stop or don't. And that kind of approach to behavior management is iatrogenic, and that means it causes more potential challenge than it treats. So we've often taught care providers redirection has to be a three-step process. If a patient is engaging in some challenging behavior, like wanting to leave or wanting to pull apart the cushions in the facility or whatever the case may be, that you first have to join them. You have to say, hey, what's going on? What's up? Oh, you need to leave, or you need to find where that noise is coming from, whatever the case may be, and then to validate that. And then by having partnered with the client, resident, patient, it's much easier then to try and redirect or distract them to other tasks. Now in Alzheimer's disease, our distraction is predicated on the fact that forgetfulness is rapid. So in Alzheimer's care, we can often distract just by getting them to move to another location. In Lewy body disease, where memory can be impaired but isn't always quite as impaired, distraction often has to involve more the fact that they're just persons with dementia have a heightened level of distractibility. So giving them 2 or 3 different options can cause them to sort of lose track of the one option they were pursuing. But whereas you can count on forgetfulness in Alzheimer's disease, you can't always count on forgetfulness in Lewy body dementia. And that's frankly why in many care settings where providers have gotten very good at using memory failure as a tool to try and manage disruptive behavior, things won't go quite as well for Lewy body patients because they're not nearly as forgetful in some cases. I've made this point in the past. I'll just reiterate it here, that for all dementias, Lewy body cases in particular, behaviors compete in real time. So increasing the frequency of a desired behavior will help to reduce the frequency of undesired behavior. And one of the best ways to figure out what behaviors we want to increase in care settings is to ask, when is the person at their best? Sorry for the typo there. It should be his or her best. And that can be a guide to what things we want to do more of. So let's go back to our woman with Lewy body dementia that's seeing small children and being agitated by that. We endeavored to increase the amount of time she spent reading or listening to opera, in part because she would have less frequent hallucinations when she was doing that, but also in part because even if she was hallucinating, she would tend to get less agitated by the hallucinations if she had something to return her attention to, so that the staff could come in and say, oh gosh darn it, you're seeing the kids again. I know that can be unsettling. You know, you and I know that that's probably your medications, but you know, let's go back to the opera you're listening to. Tell me about it. And merely use her distractibility to shift her off of the agitation, because in truth it wasn't the hallucinations that were posing the problem. It was her emotional reaction to them that the staff felt compelled to address. We worked with many, many Lewy body patients who recognize that their hallucinations aren't real, and even some of them who found their hallucinations to be interesting, not alarming, but kind of an experience to observe. And so it's really important to distinguish in Lewy body disease, where hallucinations can occur, the level of distress posed by those hallucinations. I'm going to skip over that, and I've talked about that. So let me kind of wrap up with a few key points. It's important to recognize that behavior is a communication, that communication is important, and that you can't create a behavioral vacuum, and to understand what the dementia provides for you to be able to leverage as you work with dementia behavior management. Now, I mentioned medications a little bit ago. I just want to touch on these, and then I see my time is winding down, so I'll possibly stop. I mentioned that Lewy body patients are prone at a greater rate, not all Lewy body patients, not every Lewy body patient, but some Lewy body disease patients are prone to having really negative reactions to antipsychotic medications like Seroquel, like Risperidol, like especially the older ones like Haldol. So we have to really be careful with those medications in Lewy body patients. Conversely, some Lewy body patients show remarkable benefits from going on the Alzheimer's medications, Aricept or Donepezil, rivastigmine or Exelon. These medications can have a very positive effect in Lewy body cases, and I will tell you that in all my years in working with dementia, I've never seen an Alzheimer's patient actually get better on those medications. They may help slow the rate at which they get worse. But we've seen more than a handful of Lewy body patients respond favorably to Aricept. So on our DeBART team, we will often try and use Aricept in a Lewy body patient who's naive or never had it as a way to try and improve their functioning, even if it doesn't necessarily reduce their disruptive behaviors. I've talked about the importance of sleep. Lewy body patients, like all patients with dementia, are prone to have higher rates of depression, and depression is often medication responsive, so that's a role for antidepressants rather than a role for antipsychotics in Lewy body cases. And finally, I'll just close with the notion of proactive dementia care. I think this is the most important movement that's sweeping dementia care. And it's the idea that patients with dementia, including Lewy body patients, retain the ability for creativity. And actually, in some cases, as the dementia progresses and sort of takes the inhibitions we all have away, patients with dementia, including Lewy body patients, can discover opportunities to be even more creative than they have in the past. And these are just a couple of the 3 programs that are out there, probably many, many more, probably some that you all are using in your day programming, that connect patients with dementia, including Lewy body patients, to their creativity in ways that does exactly what I said before, provides an opportunity to increase pro-social and productive behaviors to the exclusion of challenging and disruptive behaviors. So your slides have the websites for some of those programs. So here are some of the conclusions. You can read them for yourselves. And I'm nearly out of time, so I'll stop and see if we have time for 1 or 2 questions before we end.
Thank you so much. What a wealth of information that was really presented in a way that is easy to understand. I really appreciate that information. And we do want to open it up for questions now. If you have some questions that you would like to ask specifically, if you would enter those in the chat section, we will direct them and take just a few minutes for that. I know that Dr. Smith has some other appointments to move to.
Sure. And Teresa, if you could throw the control back over to Angela, maybe she'd want to put up the Lewy Body Association website slide one more time for people who want it.
Okay.
Okay, there you go.
Okay, one question, is there a genetic aspect of Lewy body dementia?
Great question. Not a real strength of mine, but I'll tell you what I know. I didn't emphasize this a whole lot and probably should have done a better job of it, but that alpha-synuclein protein I mentioned and the Lewy bodies and the substantia nigra that I mentioned are the reason that people get Parkinson's disease. And you all have probably worked with Parkinson's disease patients. Many of them will have some subtle cognitive changes, and some of them, after years and years of having Parkinson's disease, will develop a dementia. And we're still debating in the field whether there's a Parkinson's disease dementia distinct from Lewy body disease. But we know this alpha-synuclein is common to Lewy body disease, Parkinson's disease with or without dementia. And so the genetics of Parkinson's disease have a lot to offer us in terms of the genetics of Lewy body disease. So we know there are some genes associated with Parkinson's disease. What I think we're still sorting out is, are there some unique genes that give the syndrome of Lewy body disease above and beyond what we think of as Parkinson's disease? And a lot of work going on in that space. But it is the case that people with Lewy body disease in their family are at an elevated risk for developing a dementia themselves, even Alzheimer's disease actually. So there's a genetic component to Lewy body disease, but we don't have all the answers on exactly what the genes are or the full complement of the genes. And Angela may have even more information than I do on that particular topic.
From what we know, there are fewer genes identified in LBD, but they share one gene, and what's interesting is a gene that's implicated in Alzheimer's disease is also implicated in LBD even without the presence of Alzheimer's pathology. So there's potentially some genetic overlap also risk factor-wise with Alzheimer's.
One of the slides you showed, there were some differences in the early onset versus later onset. How common is it to be diagnosed at the age of 65 with LBD?
I'll let Angela give her 2 cents as well. I should have mentioned that Parkinson's disease and Lewy body disease has a greater male predominance. It's a more common disorder in men. And in my clinical experience, at least, and maybe it's a bias of recognition because we expect people to have.
Oh, I don't know if we still have Glenn.
I'm not hearing him. Maybe you have some follow-up comments, Angela, on that.
Certainly. I was just writing about this earlier today. And of course, now with him gone, my mind just totally went blank. Repeat the question one more time.
How common is it to be diagnosed at the age of 65?
Thank you. Thank you. It is actually fairly common. Even though before the age of onset at 65 is considered early onset dementia, LBD, according to literature, is a disease of the ages 50 to 85 predominantly. And so we are seeing the more frequently LBD is diagnosed, even people younger than 50 being diagnosed. So it is rising in prevalence from a diagnostic standpoint in the earlier ages, and I think the more we get familiar with what the milder stages, or perhaps the what they call prodromal, is before it actually reaches the full stage of dementia, we may find that we can diagnose it even earlier.
Wow, it's great to have research and to be able to share that information. And it seems to me that the more awareness there is about it, the more people would be willing to explore, whereas previously they may have just automatically thought it was something else.
There's a lot of information that doesn't get reported to the doctor. When you're seeking a question, an evaluation for memory problems, you might not think to talk to them about sleep problems, or a problem with lightheadedness, or a problem with, say, early urinary incontinence. They don't necessarily all trigger when you think of, well, am I dealing with a memory problem? And so a lot of information doesn't get passed to the doctor early enough.
Mm. Well, it sounds like we have lost Dr. Smith. Did he make it back in?
I'm still here.
Oh, he's still here.
Oh, there he is.
We lost him.
I'm running quickly out of time. So.
Okay. Well, thank you so much, both of you, for helping us and guiding us today. We certainly appreciate it, and we look forward to passing along. We will attempt again to get the copy of the handouts to everyone. Some people, it did bounce back when we sent them out earlier. And encourage you to look at the National Adult Day Services Association's website for future webinars and other events. And just wanted to thank you again. We will be sending a link to the recorded session within 24 hours, and hopefully it doesn't have any technical glitches or anything. So thanks for joining us today, and have a great rest of the day.